Welcome to SENADHIPAN Education Foundation again. We started this journey way back in 2012 by releasing a set of educational DVDs by none other than Professor Sion Han Kim from Korea at Taj Bhavanda, Trivandrum. Then he visited our place, and then onwards we started having contact classes and educational programs. Because of the COVID, we started having online programs like this, and the logo of SENADHIPAN Education Foundation was released by none other than Professor Palanivelu.
Now I welcome Professor Palanivelu sir, Chairman, GEM Group of Hospitals and Research Center, and the Founder President, Mathew, for releasing the logo of SENADHIPAN Education Foundation and for the inaugural address. Over to you, sir.
Thank you. And thank you, Baiju, for inviting me to be today's more remarkable event.
Then onwards, we started having online programs like this, webinars and live surgeries. We started streaming live surgeries, and we streamed anterior section, lap colorectal surgeries, lap Whipples and all. And we started having live lectures with eminent faculties and started having certificate courses. We have 3 WhatsApp groups of SENADHIPAN Education Foundation, which is having 256 members each, and SENADHIPAN Education Foundation Facebook group also. We have got a very good global acceptance. You can see that the last week webinar was attended by more than 1,000 people from more than 50 countries. And you can see the webinar videos in SENADHIPAN Education Foundation YouTube channel, and you can get it free when you subscribe the YouTube channel of SENADHIPAN Education Foundation. Today we have 2 eminent figures in the field of endoscopy as well as laparoscopy to give you an endoscopy laparoscopy interface subject. Actually, G V Rao is the person who made us proud, Indians proud, about the healthcare system in India by inventing NODS. He is the director of Asian Institute of Gastroenterology. He is a BC Roy awardee. He is a world expert in open lap and therapeutic endoscopy. He is the immediate past president of ISPBA, and he is a policy maker in many international bodies.
And taking the Walk of Fame now is Dr. G V Rao. May I request for all of you to please put your hands together for Dr. Rao, joining us from Hyderabad. And taking the...
And recently he got the award from the New Indian Express, Waiting in Line for God in 2018. A fabulous achievement by G V Rao. You can see the 2 utters by Dr. G V Rao. This I like the most as an endoscopist. You can see that the utter of an endoscopist, and as a speaker, whenever there is a debate about endoscopy and laparoscopy, he is the one debating for the laparoscopy and endoscopy interface, and he'll be beating the other speaker most of the time. And to moderate, we have Dr. Mathew, who is the Sachin Tendulkar of our Kerala team, Kerala Gastro team. He is a well-accomplished therapeutic endoscopist, a national and international educator, and down-to-earth person. Before going to the webinar, all participants are requested to mute their mic on entry. If possible, kindly acknowledge by renaming your device by yours. Participants logging from outside India are requested to reveal their identity in the chat box. Raise your hand if you want to intervene. Everybody will be given permission to unmute their mic if they want to speak. If you are on a portable device, please mute your audio and hide your video while moving. Please mute or hide your video if you are not in a casual dress event. And while Dr. G V Rao is presenting, please hide your video so that the video clarity of the presentation will be more when you hide your videos. So you are requested to hide your videos while Dr. G V Rao is presenting. Next week, we have another topic, robotic donor hepatectomy by Dr. Sudhindran, and will be moderated by Krishna Menon from UK. And you can contact us in SENADHIPAN@gmail.com. Over to Dr. Mathew Philip for the proceedings.
Thank you, Dr. Baiju, for this kind introduction and for this opportunity to be doing with another giant in the field of GI surgery, as well as in minimally invasive surgery, and probably in endoscopy too. And I think now you have taken the right person to talk on this issue. When you want to, if any surgeon wants to talk on endoscopy and laparoscopy or even open surgery combination, he is actually a surgeon come endoscopist as well as a minimally invasive surgeon. I have seen his endoscopic skills many times, and I know that he is a person who promotes the skill of hybrid surgery, and I am so happy to be with him as a part of this webinar and to listen to him. And I welcome Dr. G V Rao for this interesting discussion and topic. The floor is for Dr. G V Rao. GV, please.
Thank you. At the outset, actually, let me thank two stalwarts, actually, whom I adore most. One, Baiju, known for his laparoscopic skills across the globe, and has been promoting laparoscopy. And innumerable number of students have been benefited by his teachings, videos, live webinars. And the amount of academic work that is being done under the Baiju SENADHIPAN Education Foundation, I think is very, very formidable. And I think I wish Baiju continues doing this so that more and more surgeons and endoscopists get benefit by this. The other person I'm honored to have you, Mathew. Mathew is a endoscopist par excellence, president of SGI, down to the earth person actually, and one of those persons whom I adore for the work he's been doing and contributing to the endoscopic world. Thank you, Mathew, for sparing your time to be part of this meeting, and I hope this is a slightly controversial topic, but I thought maybe I'll try to, I'm not debating against anything, I'm just trying to see how endoscopy and laparoscopy can be integrated together. So if you see, sorry.
GV, just click on the slide, it will move.
Yeah, right. Yeah, at the turn of this century, we have seen the technical feasibility of flexible endoscopic peritoneal surgery by pioneers in expert institutions across the globe, and this took the medical world into fantasy. Actually, some of you would have seen this video, but this is the video that I would like to share, wherein from our department, we translated this experiment of doing an avian endoscopy and avian cholecystectomy to humans in 2003. For all those young surgeons who have not seen this, is an endoscopic view of the peritoneal cavity. We have got into the peritoneal cavity from the stomach after making a gastrotomy wound, and using the hot biopsy forceps, we are trying to dissect the mesoappendix here. When 2003, when we started doing these procedures, hardly any advanced endoscopic equipment was available. So after we dissected the appendix, we secured the base of the appendix using this endo loop. It is still a very popular accessory that is used on the endoscopic side. And once the base has been secured here using this endo loop, subsequently, we didn't have scissors to cut the appendix, so we had to use a snare. and a cutting and the coagulation and cutting current to cut the appendix at the base. And once that was done, we irrigated the entire right iliac fossa with povidone iodine solution, taken out that, sucked out that fluid, and at the end of the procedure, the specimen, that the appendix, was brought out to the oral cavity, and then we closed the gastrotomy using those clips. This procedure created a lot of taken people into fantasy, but also drew a lot of criticism from various circles that we are getting into peritoneal cavity, and all precautions of sepsis have been not followed when doing this procedure. But subsequently, a lot of surgeons, endoscopists took this and then started doing various other procedures which translated from animal work to human work, like cholecystectomies have also been being done. But the biggest problem was it was not consistently being done, and the repeatability of these procedures by all endoscopists or laparoscopic surgeons was of a big concern, because not everybody was able to do this procedure. And for a procedure to become popular, it has to be people should, an average endoscopist and an average surgeon should be able to do this procedure. So what happened was, actually, from lumen, we suddenly jumped into the peritoneal cavity. There's a huge leap from the lumen. We've been doing endoscopy, which is restricted to luminal side. We jumped onto the peritoneal cavity to do this natural orifice transluminal endoscopic surgery. And this sudden leap happened without proper equipment and proper understanding and proper training to do these procedures. That is the reason why it drew a lot of criticism. And also, that time, we did not understand the third space, or the submucosal space, that is the space through which we have to get into the peritoneal cavity. We didn't understand the third space properly. And what has been done in the last few years is various therapeutic options are being done in third space endoscopy. Now, we know that the peritoneal cavity can be easily accessed, safely accessed, using this knowledge that we gained about the third space. And we had a lot of technology limitations. See, we did not have any instrument to control bleed like this that used to happen. We did not have equipment to hold turgid appendix like this. And the orientation of the flexible endoscope in the peritoneal cavity was of a big concern. All these are a big concern, and we did not have any technology to overcome this. And this limited the pace at which the nodes progressed, and it could not be taken to a next level because of a lot of these limitations that happened. So like this time scale, 2003, 2004, there was a huge coverage of this, saying that this procedure would change the entire concept of surgery. That was the honeymoon period, 2003 to 2006. But certainly what happened was, because of the non-availability of technology and not everybody was able to do the procedure, there was uncertainty. People started losing confidence in this procedure. There's confusion, crisis, and people thought this procedure will never ever take off into regular clinical practice. Why this happened was, 2007, we had a NOSCAR meeting, that is the Natural Orifice Transluminal Endoscopy meeting. All the big stalwarts in NOSCAR got together in 2007 to identify killer applications. What has to be done? Unfortunately, the killer applications that were defined in NOSCAR, they defined cholecystectomy and appendectomy as the killer applications. They should have gone slower, and they should have identified a very minimally invasive procedure, but these killer applications seem to have killed the old nodes that we call, or the traditional nodes that we used to practice. So because of these limitations, a lot of hybrid technology came in. At the same time, single incision laparoscopic surgery came in. Robotics started coming in, and because of the limitations, people started thinking about hybrid procedures that could be done to overcome these limitations on the flexible endoscopic surgery. So parallelly, what happened was, we had endoscopy, which was developing rapidly. We had laparoscopy, which was evolving very rapidly. So each specialty had its own pros and cons, like flexible endoscopy. Flexible, it is maneuverable, it had narrowband imaging, but the cons were orientation was difficult, accessories were limited, and energy sources were limited. But on the laparoscopic side, the rigid instrumentation made dissection, resection, anastomosis, hemostasis very safe. And we had ICG and infrared laparoscopy that came in. The biggest disadvantage was we were not able to do any organ preserving surgeries in this. So what happens is if you combine the pros and cons of both endoscopy and laparoscopy together, then we have emergence of a new specialty called as endo-laparoscopic cooperative surgery, wherein the advantages of both the things can be taken together to make sure that these procedures become very viable. So traditionally, the endoscopists who were limited to the lumen, they started going out of the lumen, and the laparoscopic surgeons who were traditionally outside the lumen doing resections started getting into the lumen of the GI tract. And obviously, there was an interface between these two. There were some gray areas wherein endo-laparoscopic cooperative surgery seems to be very, very useful. And this was a term that was coined way back in 1937. It is nothing new to us. And it had various names like intraluminal laparoscopy, endogastric surgery, laparoendoscopic surgery, endoluminal surgery. But what has become popular is the laparoscopic endoscopic cooperative surgery, or it is called as the new nodes in the current day clinical practice. So what it means is this can be done either be using flexible, rigid, or a hybrid technique. The hybrid could be the instrument could be using flexible and flexible instruments, or rigid and rigid, or flexible and rigid instruments. And the axis could be either dual or multiple axis, or you're using a laparoscopic port in sometimes. I'll give you a couple of examples what has been happening. Metabolic and bariatric endoscopy is becoming very, very popular. Various endoscopic therapies have evolved, but all these have evolved on the basic principles of laparoscopic bariatric surgery. So we have very popularized the laparoscopic sleeve resection on the laparoscopic side, and on the endoscopic side, they started doing this endoscopic suturing to cut down the lumen, and ESG procedure is becoming popular on the endoscopy side. So these endoscopic procedures that are becoming popular and are having a competing with the laparoscopic procedures are all based on the principle that have evolved from the laparoscopic side. And endoscopic sleeve gastroplasty that is being done is gaining clinical entry, and it is indicated in not all patients, but a certain group of patients seem to be benefited by this. But the biggest disadvantage of this endoscopic sleeve gastroplasty is a semi-blind procedure. You're taking full thickness bites at the endoscopy side. We don't know what is happening on the serosal side. So people are happy taking these bites on the mucosal side, and they feel that it is full thickness endoscopy bites. And then, unfortunately, this is not what happens. Fortunately, because the stomach is extensively perfused, it takes the traumatic insult without much morbidity in this patient. So endoscopic sleeve gastroplasties are being done. But you can see this, whenever you take full thickness bites, it's only a couple of bites of full thickness. Rest of them are just mucosal or submucosal bites. So what I personally believe is actually we should be able to use a needle scope along with this endoscopic sleeve gastroplasty to make sure that we're getting full thickness bite, and also we are avoiding any trauma to the adjacent structures during this procedure. And you can see this stomach is profusely perfused. It is ICG to show that stomach is extensively perfused both on the greater curve side and the lesser curve side, and it takes a lot of traumatic insult even if you ligate majority of the vessels. So I'll show you this video of what happens actually. This is one such patient who underwent the endoscopic sleeve gastroplasty. You can see that not all bites are full thickness. And if you see the endoscopic side, you can see this something that looks like a trabecule in a patient with ulcerative colitis. All these full thickness sutures that we think are full thickness sutures are given way, and this causes some sort of bacterial overgrowth in the stomach and is responsible for some of these patients having diarrhea in these patients. So what ESG has shown is that we can start the practice of endoscopic suturing, but this needs to be further improvised to make sure that we are getting full thickness bites on the stomach side so that the long-term results of these procedures are very good. You can see this ESG done, but only 2 sutures of full thickness. The rest of the stomach is absolutely normal. So this patient comes back with a laparoscopic procedure. Likewise, we started doing the Roux-en-Y procedures, and then the endoscopist borrowed this idea and started using this endo barrier or a Revita procedure, which mimics the laparoscopic option, but we still have to wait for the long-term results of this. But this certainly seems to be a bridge to laparoscopic surgeons with huge, large BMI. Some of these patients with comorbidities can be taken to endoscopic procedures initially, subsequently taken for laparoscopic procedures. Gastroesophageal reflux is another area where the endoscopists and laparoscopic surgeons seem to be competing. There are innumerable number of procedures that came on the endoscopic side. The gastroenterologists, we all know that, we agree that PPI is the mainstay in the management of GERD, but at the same time, a certain percentage of patients seem to require some sort of an intervention. Laparoscopic fundoplication has been this gold standard, but various endoscopic options have come. But surprisingly, all of them, they came and they went off because none of these procedures stood the period of time and they could not show the efficacy similar to laparoscopic fundoplication. We also started doing some procedures like LES, gastric stimulation, by inserting an electrode at the LES, or doing procedures like arms and all this. But all these procedures are still awaiting long-term results before we can say that these can be an absolute replacement to conventional laparoscopic fundoplication. A lot has to be learned from the techniques that we do, what we do, how it is done, why it is done on the laparoscopic side. And now we have this newer anti-reflex procedures which are coming on the endoscopic side, which are coming closer to some sort of fundoplication procedures that we do. We are sure that in the days to come, we'll see more and more of this, but this is just started on the endoscopic side from what has been learned on the laparoscopic side to see if some of these procedures can get benefited by endoscopic fundoplication procedures, but we're still awaiting for an ideal technology that can be comparable to laparoscopic fundoplication. In spite of limitations that we have, not all procedures can still be done endoscopically, like this denture which got into this esophagus, which we could not remove endoscopically in spite of all the efforts, and like this esophageal diverticulum. These are the things which require some sort of an endoscopic laparoscopic assistance so that the patient safety is must. And then you can see this we have dissected out the entire diverticulum, stapled it under endoscopic vision. And here we are taking out this huge impacted denture under endoscopic vision. Likewise, achalasia cardia, we have two competing technologies. Now we have a Heller's myotomy and a POEM procedure. Both of them seem to be equally popular. POEM is getting popular. POEM has shown that endoscopic, we can start dissecting, we can start cutting muscle. This is one procedure which has stood the period of time. Beautifully, we can see that the entire muscle, the longitudinal circular muscle, depending on what the endoscopist practice, can be cut in the full length. And these patients seem to have immense benefit from this dysphagia that they have. But surprisingly, some of these patients have reflux. On the laparoscopy side, we usually do a partial fundoplication. But reflux in the POEM seems to be the critical review. And then of late, people started doing endoscopic fundoplication. But this still has to await for long-term results before we can say that this is ideal. But as in today, POEM is a very good procedure. But the reflux following this has to be tackled somehow. And as in today, the options would be POEM plus fundoplication, a single admission. This obviously, I don't think this is an indication because not all patients require fundoplication. POEM followed by a lap fundoplication. Yes, some of these patients who have reflux, they can be considered for fundoplication. POEM for plus endoscopic plication is an evolving technology. We still have to wait for this. And a lot of what we learned from laparoscopic surgeons has been translated onto the endoscopic side. Now, the biggest thing that has happened in the last decade or so is better understanding of this third space, which is the submucosal space. And because of cross-sectional imaging, umpteen number of new pathologies which are undetected, and obviously because of augmented use of endoscopy, a lot of these SETs or submucosal epithelial lesions, tumors have started being detected. And we started understanding the biological behavior of this. And we also know that it is not required to do radical resections for this, and segmental resections are possible. And we also know that we have better functional outcomes when we do this localized resections. So these SETs are becoming increasingly being detected, and they obviously require treatment. And so new nodes has opened up this interventional endoscopy, and we have various endolaparoscopic cooperative surgery procedures that are being designed to do these various subepithelial tumors that we encountered in the stomach, esophagus, duodenum, or even in the colon, and have been variously labeled depending on the amount of endoscopy procedure or the laparoscopic procedure that is done and the amount of cooperation that is required to do these procedures. So these procedures, you can see this now, and on the endoscopic side, you can do this stir procedures, it can be resected, but there are limitations to the size of the tumors that can be resected. Now we have clearly defined which procedures can be done endoscopically, which procedures can be done laparoscopically. And you can see this ESD on the endoscopy side, it is being shown to be very, very effective. And the results are very good, especially if you select the patients very well. Now, there are some instances wherein this cannot be done, especially tumors close to GE junction. Here we have done a PEG tube, and through the PEG tube, we inserted the conventional harmonic scalpel. And this is the GE junction tumor, which would have required some sort of a proximal or a total gastrectomy. And under endoscopic vision, we are doing this resection. And then at the end of the procedure, we can get this specimen out to the oral cavity, and the PEG tube can subsequently remove. So this is an advantage of using a combined endoscopy laparoscopy technique, wherein we can use the energy sources and the rigid instrumentation that is available on the laparoscopic side, and you're avoiding a major open surgery or even avoiding a laparoscopic procedure. Likewise, this is another procedure. You can see this is a GIST. It can be done very simple laparoscopically, sleeve resection, but we just want to know at the same time what is happening on the endoscopic side also to make sure that the lumen is not being compromised, we are not taking any additional things. So as we are stapling this, we've got dissection of the thing. You can see this, the staple line, you can see very clearly how it gets stapled here. This is one biggest advantage. You can see that is the staple line, that is stapled. So this is basically an endoscopic asset. You can see this as you're firing, you can see the staple line here. This is the beauty of using both endoscopy and laparoscopic procedures simultaneously. And it has shown to be definitely advantageous. And you can see, check for any leaks. Actually, after that, you can distend the stomach, make sure that you do not have any leaks at the staple side. And if there's any intervention that has to be done, it can be done. Likewise, this is another procedure, a large disc along the lesser curve. This would have conventionally required a total gastrectomy or proximal gastrectomy. You can see this under endoscopic guidance. Now we identify this. Now we identify that. Actually, then we make a gastrotomy. You can see this. You can make a gastrotomy, and then we can do a resection, wide resection of this gist. Under endoscopic guidance, we make sure, and as you're doing this, the endoscope guides during this entire procedure, and I'll show you in a minute or so the endoscopy, that is the endoscopic view. And once you are resected, these are procedures wherein the endoscopic surgeon and the laparoscopic surgeons have to work together, because the endoscopist also has to know how he has to move in the peritoneal cavity, how he has to stabilize the image in the peritoneal cavity. So you can see this is the laparoscopic resection of the gist that is being done. At the end of the procedure, this can be easily removed by the laparoscopic surgeon and put it in an endo bag and retrieve. But here what we are trying to do is, because we have to learn this, we have to learn the movement of the scope in the peritoneal cavity, we get this scope into the peritoneal cavity after this resection. And you can see this, we are holding this gist with this hot tooth, rat tooth forceps, and trying to push this into the endo bag here. So this is how the endoscopic and laparoscopic surgeons have to work together, so that each person knows the movement and what can be done on the endoscopic side and what can be done on the laparoscopic side. Now here again we have an endoscopic. You can do a full mark out the lesion which is not seen on the serosal side, and then once you have marked out the thing, then you can do a full thickness resection of this lesion. So this lesion is not seen on the serosal side, not palpable laparoscopically. So you do a full thickness resection of this laparoscopically, and then you do this suturing. Again, you can see this is the biggest advantage of using a combined endoscopy and laparoscopic procedure, especially when you're doing this lesions in the duodenum. So these procedures have shown to be very, very useful, and the complication rates are absolutely nil in these procedures. And we have a lot of these procedures wherein you can combine this endoscopy, under endoscopic assistance we can do, and the complete resections are possible in majority of these patients. Early gastric cancers are being treated actually endoscopically. There are a lot of data to show that ESD, Japanese have shown that these procedures can be done very, very safely. But it is always, sometimes it has become mandatory that to make sure that we are not having any serosal tears or perforation, these procedures are done under laparoscopic vision. And then this is one procedure, an oncological procedure, wherein we don't want any spillage of the cancer cells into the peritoneal cavity. You can see this, we have submucosally injected the lesion from the endoscopy side. We made this lesion and then see it on the laparoscopic side, make a seromuscular incision on the laparoscopic side on the area that is marked out. So you know that this is the area of the tumor. Now, once you have done this, you invert this lesion, this entire lesion, taking this seromuscular sutures. So you're inverting this entire lesion, the malignant lesion, onto the luminal side. And to make this more prominent during this procedure, you can always insert some Surgicel or a gel foam to make this lesion very prominent on the endoscopy side. You can see this, we start inserting some sort of Surgicel or a gel foam here to make this lesion more prominent. Now, once this is done, the entire seromuscular incision is done, we can go onto the endoscopic side and do a submucosal resection like what has been done. So we are not, this is what is called as a clean procedure. We are avoiding any spillage of the cancer cells into the peritoneal cavity. And now we are talking about full thickness endoscopic resections and laparoscopic lymph nodal dissection. There is some data to show that this is feasible, and more surgeons started practicing this procedure. And you can see this, though we think that is not a big thing, but a lot of data seems to be coming from big centers from across the globe of large number of these procedures being done in stomach, esophagus, duodenum, colon, and with minimal morbidity and mortality in these procedures. And now, depending on the extension of the lesion in the mucosa, submucosa, or it going into the muscularis propria, the longitudinal muscularis propria, or going into the serosal layer, various procedures have been designated to this. It is not that one procedure can be done for all of this. Now, it all depends on the amount of extension this lesion has got across the gastric wall. Various procedures have been designated right now, and it's also shown in the literature what is the role of the surgeon, what is the role of the endoscopist, and what is the location where it has to be done, and what is the closure type, and how the endoscopic specimen has to be retrieved. Now we have definite roles which have been designed, designated to endoscopists and the surgeons to make sure that these procedures are done, because all these procedures have their own pros and cons. So unless and until you understand all these procedures, it is very, very difficult to do these procedures. So people practicing these procedures should understand the limitations of each of these procedures. And as we get acclimatized to this, we know what is the role of the endoscopist in this procedure, what is the role of the laparoscopic surgeon in this, and wherein both of these people can combine their expertise to minimize the resections and expedite the process and expedite the recovery of these patients who have these procedures. And these hybrid procedures are becoming very, very popular. And we have a separate breed of surgeons, separate breed of teams who are building up to do these procedures. Now, as we are doing this third space, accidentally, we keep seeing the mediastinum. Now, unfortunately, whenever we see mediastinum, especially people think again, it's an area where we should not traverse. Now, as in today, a lot of mediastinal incidentalomas are also being picked up. A lot of biopsies are being done. This is either done by endoscopic ultrasound or by endobronchial ultrasound. But there are a lot of limitations of this because only an FNA or an FNB can be done. But full thickness lymph nodal or full lymph node biopsies are not possible during this mediastinoscope or during this FNA or mediastinal US FNA or FNB. So we have some role. So now surgeons or endoscopists or third space endoscopists are becoming very, very aggressive. Now they're exploring the possibility of getting into the new terrain. I call it as a new terrain. The mediastinum seems to be the new terrain, and we're getting into the mediastinum. And with the advent, you can see this beautiful thing that you can see once you get into the mediastinum. Like we have now good experience with doing this full thickness and stir procedures. It is possible that you can do full lymph nodal sampling in select group of patients with good ease in these patients. On the node side, because of the limitations that we have, a lot of hybrid procedures came in. Transvaginal procedures became popular, and you can see this transvaginal, we insert this, and transvaginal cholecystectomies have become popular, and these hybrid nodes have become very popular. And in female patients, narrow specimen extraction has become very, very popular because this decreases the scar, and obviously because there is no big scar, it decreases the tissue inflammatory response, and patient seems to be recovering faster. So as female patients, this has been used extensively to extract specimens. There is a lot of consensus to show that this is becoming a very popular route to extract the specimen in during laparoscopic procedures. And you can see there's a lot of these procedures are being done. And even these hybrid procedures and pure procedures, there is a lot of data that is coming in to show that these procedures are feasible, can be done in select centers, and with minimal complications. We have a German registry which shows the overall complications is very less. It is comparable to laparoscopic procedures. And we have various meta-analysis which have come in to show that these procedures are safe. It can be done. And we have this Euronotes registry which shows that some of these procedures, especially in centers of excellence which have been practicing, can be done very, very safely. One competing technology which has come is the transanal endoscopic microsurgery, or the TEMS procedure. This is a competing technology for nodes procedure. Now, initially we used to restrict ourselves to the luminal mucosal side, started doing some resections, but with increasing expertise, now there are a lot of, even in our center, we do this transanal mesorectal excisions actually in select group of patients. And you can see these have shown to be very, very having equally good results, especially if you have surgeons who are trained to do these procedures, and we are able to do this procedure in equally same time like what we have been doing in the laparoscopic side. So these procedures are becoming very, very popular. And in the days to come, we'll see more and more of these transanal endoscopic microsurgeries that could become very popular. So traditional nodes, what has happened, it's a rare instance wherein the procedure concept worked out even before we had some technology. Laparoscopic instruments, although adaptable to transvaginal procedures, have to be optimized. And physicians and industry are working together and developing these procedures. And then we have a lot of lessons we have learned from traditional nodes, which are being incorporated. But the limitations that we had in the nodes procedures of platform stability, of instrumentation, tissue closure devices, anastomotic devices, all these were the limitations. And there are a lot of working groups which worked on this. And when I was working way back in 2004, this is a cartoon that was done by one of the engineers. Actually, in 2004, I was working for one of the industry for development of some of these accessories. When I first discussed about this procedure, he drew this diagram for me that he said, this is what you require, doctor, for these procedures to become popular. So some of these things have been translated on the clinical side. And what we required was to totally deconstruct the existing endoscope and do something totally different. Now we had the sequence of that, what happened in 2004, various engineers incorporated, and then a lot of people across the globe work together for the development of these newer scopes that could be easily maneuvered and could have some amount of triangulation. But somehow, actually, all these technology was uniformly shelved by major industry players for various political reasons, or basically because we did not have adequate expertise to translate this into clinical side. Simultaneously, we had the robotic systems which are getting incorporated on the robotic side. And you can see this, we have the Da Vinci on the laparoscopic side. And then we with the National University of Singapore, and we have developed this instrumentation, 2 robotic arms that can be passed through the double channel scope. and then you do this endoscopic submucosal resections. So the biggest advantage of this was we're able to have two ports in this, and we are able to do a procedure like what we do on the laparoscopic side. This is a very small series, but it is a giant step for endoscopy, and we feel that incorporation of robotics is going to make a big dent in endoscopy side, and a lot of platforms have now come in to show that robotic endoscopy is the next big thing in endoscopic side. And we have a lot of newer robotic systems that are coming into clinical practice with various designs, concepts, and specification. And we have the future scopes which will be designed like this. Simultaneously, what has been happening is actually we have this, we have done this laparoscopic cytoscopy. We have this cytoscope which can be put on any lesion on endoscopy side and make an on-table diagnosis. So we use the same cytoscope on the peritoneal side, put this cytoscope on the nodules to make an on-table diagnosis of a malignant nodule, and you can see this tumor emboli in the vessel. So this is the concept of using an endoscope on the laparoscopic side. And what happened was now we have this artificial intelligence that has come in a big way on the endoscopic side. Basically, it's an ability of a computer to perform tasks and cognitive functions like human beings. Now on the endoscopy side, we have this technology called as endobrain, wherein artificial intelligence and endocytoscopy are inculcated together. So now what it does is, now you put this scope in and it touch the lesion here. Now this makes, it analyzes the thing and tells us whether this is a neoplastic lesion or a non-neoplastic lesion. So now and this aids in targeting biopsies. So you can see this is artificial intelligence that has come onto the endoscopic side. And now we are able to do artificial assisted endoscopy, and it assists in taking sampling, especially when we are not sure, and it shows that it's a good sample to take, and it shows this is a benign thing or an invasive cancer. So this is what has come on the endoscopy side. Now, for the first ever time, we have used this on the laparoscopic side, like how to use for side endocytoscopy. So we use this endobrain in a patient with peritoneal metastasis like this. A diagnostic laparoscopy was done, and you can see this. I've used this endobrain through the laparoscopic port. You can say this I've used the same technology like I used initially for cytoscopy, and now here I make an on-table diagnosis of a neoplastic lesion versus a non-neoplastic lesion. You can see this. I put this scope in touch with the thing, and it shares it's a neoplastic lesion. You can see this is the narrowband imaging, and then I touch the lesion. Unfortunately, it was able to pick up because it also showed that it basically now it is being used for colorectal disease, and now it is shown that we can pick up lesions and we can make an on-table diagnosis. This is, you can see this is, it shows it's a 99% in neoplastic lesion. So this is a combined endoscopy laparoscopic procedure or a laparoscopic endobrain that is used to make an on-table diagnosis. Now we are talking about all this, but is conventional anatomy applicable in current day endoscopic laparoscopic practice? So if you see conventional anatomy, all the clinicians, all of us claim that we all know the anatomy inside out. You ask any medical student or doctor, they'll say that I've read Gray's anatomy inside out. Now this is a myth, basically because Gray's anatomy was written outside in. It is not written inside out. It was Henry Gray wrote the anatomy outside inside, and the conventional anatomy is always whatever Henry Gray is written is from outside inside. But what we practice in minimally invasive surgery and endoscopy is from inside out. Like we started doing hernia surgery from laparoscopic surgery from inside out, and also the endoscopic on the endoscopy side. So what happens is when you see from the surgery, it's outside in, from endoscopy, it's inside out. So there you're just seeing what is inside, but you don't know what is happening on the outside. So like what has happened to the laparoscopy side, we have rewritten the entire anatomy of the inguinal canal based on the for the laparoscopic surgeons. Like this, what has happened. So we have to rewrite the entire anatomy for the endoscopists to understand what is happening in the various layers of the stomach or the colon, so that they can safely get into the peritoneal cavity. So we have to unlearn the outside in anatomy, what has been traditionally learned, and to relearn the inside anatomy, out anatomy, what is practice right now. There are a lot of structural variants that we see on the outside which have to be learned, and there are a lot of limitations, the momentum which limit the distensibility of the stomach in a morbidly obese patient, and the vascularity of the stomach, the various anatomical things, and the vascular malformation that we have to know. Now, the other thing that we have to know is the minimally invasive surgery is all about working in positive pressures in potential spaces. Now, is conventional surgical physiology applicable in current day practice? Now, we all been doing this open surgery wherein the intra-abdominal pressure is equivalent to the outside abdominal outside pressure. But surprisingly, when we started doing the nodes procedure, we know that the intra-abdominal pressure is now, we have the positive pressure in the peritoneal cavity as compared to the open surgery. And when we come to hybrid nodes, actually there is positive pressure both in the lumen and obviously in the peritoneal cavity. This obviously initiates a lot of physiological changes. And when you're talking about mediastenoscopy, you understand that we have positive pressure in the mediasternum, in the lumen, and also in the pleural cavity. All this initiates a lot of changes, and there are a lot of limitations on endoscopic insufflators. They're fully not automated. They're semi-controlled. High pressure delivery of CO2 in the third phase could cause some limitations. And then we have to understand the physiological changes that occur during this process so that these can be tackled very effectively. So we have to relearn and better understand the anatomy and physiology in context with the new nodes and also with the hybrid endoscopic surgery. Also, the cross-sectional imaging for advanced endoscopy, we have sagittal sections, transverse plane, and a coronal plane. As with transverse coronal sections are very good for esophageal this thing. But when it comes to stomach, if you want to do any endoscopic procedure or a bariatric procedure, I personally feel you have to get sagittal section anatomy understood very well, because understand the anterior-posterior relations, especially walled-off necrosis. If you want, I think these are very, very helpful. So how much of the wall-off necrosis is posterior, how much is extending across onto the anterior side. And when you're doing any bariatric procedure or any of these procedures, that or any of the subepithelial tumor, the anatomical location and the orientation of these lesions, especially when you're taking the sagittal sections, which I personally feel are very useful to show anatomical structural abnormalities, adjacent visual structures, blood vessels, and also collaterals. Now, all this requires a lot of training. We did not have training models initially to train this combined endoscopy-laparoscopy procedures, but now we have good simulators which have come in to train people, because hardly few centers across the globe who can train people in these procedures. But we know that now these simulator devices are very helpful, and they have shown that using this, it is very easy to learn these procedures. And there are a lot of artificial intelligence incorporated models that have come in to make sure that these procedures can be safely learned. And there is data coming in to show that these procedures are helpful to train and safely translate both these endoscopic and laparoscopic surgeons to do these hybrid procedures. So the GI endoscopy-laparoscopic cooperative surgery, novel procedures that minimizes invasive damage to patients and preserves physiological function of the residual stomach. Currently, many physicians can utilize the advantages of laparoscopic endoscopic cooperative surgery for gastric SACTs, even located at the EG junction, by avoiding conventional total gastrectomy or post-renal gastrectomy. This technique requires close cooperation, as I told you. And the GI endoscopy-laparoscopic cooperative surgery is a rapidly evolving specialty. Many of the endoscopic procedures have evolved over surgical rationale and principles. The science behind surgical techniques led to better understanding of science and helped the development of innovative hybrid procedures. We need to relearn anatomy and physiology applicable to emerging procedures. Endoscopy has replaced some, aiding some, competing with some, complementary to some surgical options. Endoscopic assistance obviously improves surgical outcomes and vice versa. And new nodes, the old nodes is still viable. It's an acceptable concept. It is not that it is out of clinical practice. It is introduced early in the time scale of endoscopic evolution. There has been a giant leap from the lumen to the peritoneal cavity with limitations on expertise and technology. The new nodes is evolving in a grand vision with a robust platform, and I'm sure This technology will make the old notes a reality soon. Mediastinum seems to be the new terrain for endoscopists, and a newer understanding from inside outward and the physiology has to be known. And then TEM technology is supportive. Need harmonious working relations between surgeons and endoscopists in animal rooms, operating rooms, endoscopy rooms, and meeting rooms, so that cross-learning across specialties is possible. And we are aiming at a holistic, safe, acceptable, revolutionary notes. So what happened was, initially I showed you that there was crisis. People thought these notes will no longer come into clinical practice. This new notes or hybrid surgery has opened up this, and they started exploring this. And there's a new confidence that is being gained to make this a reality. Likewise, basic sciences also seems to be getting incorporated into this. We have a beautiful basic science lab, which is doing a lot of work. We started doing culturing these cells, injecting the LES to augment LES procedure. And this, the latest thing what we have done is actually on the rabbit experiment, actually we started doing some esophageal regeneration. Now this is one such procedure which again requires endoscopy-laparoscopic assistance. Now initially we have removed the longitudinal circular muscle coat in the rabbit, and then we have put this scaffolding and we have grown the esophageal muscle. Now what we have, the next experiment that we are being planned is actually full thickness resection of the esophagus here. A fully covered stem is being covered with that scaffold, which is having this pluripotent stem cells. And we hope that we can regrow a segment of esophagus. And if this happens actually, and I think a lot of things that we have been doing, a lot of resection that we have been doing could be lessened. So to conclude, actually this notes and new notes, imaging enhancement, cooperative surgery, robotics, artificial intelligence, advanced scope, basic sciences, all seem to be helping in making this new technology or an endoscopy, laparoscopy, a big thing. And the technology seems to be coming in a big way. And we have industry and superheroes who are working on closure devices, energy sources, dissection of extraction techniques. And I just hope all the surgeons and endoscopists, all the superheroes comes together, working together for a holistic surgery, endoscopy interface, make this a reality of the future. Thank you so much once again for the patient hearing.
Brilliant talk as usual, Dr. G V Rao. We really enjoyed the science fiction or the roller coaster ride that was happening, the endoscopy, laparoscopy interface. And actually, there are a lot of things to be researched and put into practice. I hand over the mic to Dr. Mathew Philip to take the questions.
GV, it was a wonderful talk and it's a wonderful exposition, and you kept a very good balance between endoscopy and surgery. And yeah, from your talk, I found that you are very careful in not annoying any endoscopist as well. You traveled a path in between those two. I really appreciate and thank you for being so neutral, and you have selected areas which are actually beneficial when the endoscopy as well as the laparoscopy can be combined. That's an excellent thing. And as we know that in the excellence in cross-sectional imaging and diagnostic qualities of improvement of endoscopy, that has actually made all this difference now to do a hybrid surgery possible. And also, you know that the introduction of artificial intelligence in all the areas, not only in endoscopy, but also in surgery, robotic surgery. And now I'm sure in a couple of years, robotic endoscopy will also become a practice, because now we take a little more time for endoscopic submucosal dissection, and this time can be reduced to significantly low, as studies have shown that probably ESD can be done very fast. And also now we find it sometimes difficult to get locations difficult, or because of the gravity, positional gravity and all, no, sometimes the ESD becomes difficult. So all these can be actually circumvented when you actually in robotic endoscopy come into the field. And Baiju, you can ask the questions, but I could not see very well the questions there. And you can ask questions, and while questions are coming on, I can make some comments too.
In the chat box, there are not many questions From me, shall I ask you a question? Can you please elaborate on the transoral mediastinoscopy? From where you go, where you puncture, with what you go, etc.
Yeah. Now, this is actually this is still not coming to clinical practice. This is being done on the animal work. Actually, whatever videos that I've shown are being done the animal work. Actually, right now. Now, the biggest advantage actually we have to take a lateral incision. We cannot take an anterior. It has to be a subcarinal incision because not above the thing. Subcarinal incision on the lateral side. We take an incision not on the anterior wall or the posterior wall. We make an incision on the lateral side so that we can get into the peritoneum, into the mediastinum. Now, this is the biggest thing that has happened is because when we're doing poem, Mathew will agree with me. A lot of times both the longitudinal and the circummuscles are split, and you're seeing the mediastinal pleura. So now this is the advantage that is taken now. But we have to understand that this is not so very easy because it communicates with the peritoneal cavity. So if we are not having controlled pressures in this, it is likely that the patient can have massive surgical emphysema. And right now, the biggest advantage on the endoscopy side is we started using carbon dioxide instead of air, what we used to use. So if we have controlled thing like what we have on the laparoscopic side, these procedures, I think in future, I think could be very useful. Even when we're doing this poem procedure, initially there was a lot of apprehension, thinking that there could be a lot of physiological changes, but the anesthetists have got adapted to this actually very fast. And also this mediastinal thing, actually, it is just an evolving thing. It is just a clinical thing that people are thinking, because now that we're seeing mediastinum, why don't we get into the thing and see if we can get a full nodal biopsy in this?
Another area.
GV,
Sorry.
no, I just want to make a comment on this juncture. Is actually the biggest discovery which happened in endoscopy. One is that the rediscovery of third space.
Yeah.
Because everybody knew there was the submucosal space. But now it is actually, once you go with the scope only, you realize such a huge space, you can do many things there. And that actually helped a lot of things. And what GV was telling about entering the mediastinum, it is possible because you do not cut directly. You enter the submucosal space, you go at a certain distance, you split the muscle, go inside the mediastinum, take out the node, whatever it is, and then come back. Another thing is, instead of air, we found out that carbon dioxide is better. Why? Because it is absorbed very fast. And also when we started doing poem, we never knew that we have to control the pressure of carbon dioxide because there are no machines also on that. Now we know that at that time we were using indigenous techniques to actually control carbon dioxide. Now we have got machines for that. And there is another question from Pramil regarding what is the role, Pramil is a GI surgeon at Lisie, what is the role of laparoscopy-assisted ERCP in difficult situations like Wilrose 2? GV, your opinion and your experience on that.
Yeah, actually, I thought because this laparoscopy endoscopy interface, actually, I didn't want to cover this. Actually, there are a lot of other procedures like what we do, wherein we do use combined procedure like laparoscopic assisted enteroscopy, intraoperative ERCP. We use the thing wherein we do lap cholecystectomy, we do an intraoperative ERCP. And in altered anatomy, especially if you're not able to get these things. Now, these procedures are slightly cumbersome, but it can be done. See, but again, my gut feeling is can be done is not necessarily should be done. Please, let us be very, very clear. Now, it can be done. Anything can be done, but it's not that it should be done. It can be done in select few centers who have this expertise to do this, and they know the limitations of the procedure. So even in altered anatomy, now we can have a scope, can make an enterotomy, I mean, and then put a scope and do the ERCP, yes, especially after a ruined by GP. Actually, you can get into the stomach through a laparoscopic port, get into the residual stomach and do an ERCP. All these are possible, but again, you have to know the limitations of this. If you have the limitations, yes, understand we can do this procedure very safely.
GV, another interesting finding you have shown is actually a very good thing for me. And here I have seen that you presenting narrowband imaging inside the peritoneum.
Yes.
But you started stepping into diagnostic era of endocytoscopy also. Because I am a person who does endocytoscopy. I got the endocytoscope and I'm actually using the endobrain also to show whether the polyps are actually a neoplastic or non-neoplastic. and we actually stain with a certain stain like crystal violet and methylene blue. So using these stain inside the peritoneum, is there any problem with using these stains in the peritoneum?
No. Actually, we don't have any use this actually now. Actually, these are being time tested right now. Now, the biggest technology that we have right now, initially, actually, in fact, actually, the Olympus actually initially asked us to evaluate the role of narrowband in laparoscopy. So we have done extensively. Maybe would have collected almost about 10,000 pictures of various things to see if narrowband picks up some lesions on the peritoneal side. But surprisingly, this narrowband imaging did not have any big role on the laparoscopy side. So the only thing is that we staining this endocytoscopy is used. The biggest thing that we have right now is the infrared laparoscopy that has come in a big way for us, and that is very useful for the laparoscopic surgeon. So, and on endoscopy side, you have narrowband imaging and infrared laparoscopy. I'm just trying to work on an interface between narrowband and laparoscopy. Now, I think next week we have some scheduled cases, and hopefully we'll do something more interesting.
Endocytoscopy is actually evolving, and still,
yes.
for colonoscopy, it's it's all known. But upper GI, I'm also learning in the field of upper GI. But
we got this published actually. This cytoscopy, laparoscopic cytoscopy was published. Actually, we got this, especially in patients with chronic pancreatitis. We checked it on table, and then we got this publication done way back.
And I think that's a good technique. And in lower GI, I found it's quite useful. Upper GI, I'm just studying on that. And I think it's especially with the help of endocrines, an artificial is quite useful in that. And Baiju, any other questions from your side?
See, what is the status of endorobotic now? Actually, shown some procedures being done in pigs or something. What is its status?
No, actually, endorobotics now actually is being translated right now. Now we have actually ESD procedures. We have done the first series of ESD. Now the first generation of the scope has already come into clinical practice. Now they have started a randomized control trial in Prince of Wales Hospital. Actually, Philip Chu and his team have started the first randomized trial. And then I think we just await for this. Actually, that is one center which is approved to do this procedure. They've got the ethical clearance. So I think the concept that I showed you has come into clinical practice now. We're just awaiting for that scope to come available for other people to practice now. But definitely, it has shown that we can start doing resections, suturing, like what we do on the laparoscopic side.
GV, in Singapore National University, I have seen that they have actually in their lab, they do this procedure some years back.
This is the same instrument that I showed you, actually, what was done actually. So the first clinical trial was done at AIG actually. And now this instrument now has come into clinical practice and what is being used at Prince of Wales Hospital.
I saw it in animal models. That was many years back. Probably.
Many years back, yes, absolutely right.
Yeah, there is a question from Darshan Nayak. For full thickness resection of gist along the lesser curvature close to GE junction, how far it should be from GE junction for safe resection avoid proximal gastrectomy?
So see, basically now, see, like what we do for bariatric surgery, we put the tube and then we do a sleeve right now. So even the same principle that you have, suppose if the GE junction is not involved and we are able to get that 0.5 to 1 centimeter margin of a gist, I think it is quite adequate to do this local regional resection.
GV, I just want to, Baiju also, we have some experience in combined resection on GE junction tumors with laparoscopy and endoscopy. And Pramil is the person who usually does that. And we actually use the endoscope to visualize the tumor, and laparoscopy you make a gastrotomy, and then actually he dissected so well. And we were actually many times struggling to do endoscopy resection because at that angle, some days you get lost and you may not be able to do that. And Pramil actually has done that, and I think that is a very good technique where laparoscopy as well as endoscopy combined, we can actually do the procedure.
Yeah, what Mathew said is very right actually, because close to GE junction, we have to do the scope has to be in retroverted position to do this procedure. And to do the procedure in a retroverted scope is quite difficult. And that is where actually this combined endoscopy laparoscopy procedures become very popular.
This is one of the areas where endoscopy and laparoscopy combined will be helping a lot. Yeah. There is a question for you to AIG that can surgeons learn some endoscopy procedure by any fellowship course?
Yeah, we do. We have this thing. There's an ongoing thing. Actually, we have actually almost about 10, 15 people at any given period of time who are coming here. Actually, they spend time both on the endoscopy side and the laparoscopy side. Actually, we have a beautiful animal lab right now. People can come learn. Actually, most welcome. We run these courses very regularly. COVID time, I think it's become this thing actually. But now, once COVID goes, I think we have a beautiful animal lab actually, and people can come for both the live sessions and also for the hands-on.
Baiju,
Yeah.
I can add on that what GV told. I have visited that lab many times as a faculty
Yeah,
training. So I think it is one of the best animal lab I have seen ever in the world. It's one of the best because they have got how many stations, so many stations are there. Actually, you can use for hybrid procedures as well as for all advanced endoscopy procedures. And I think that is one of the best animal lab where you can get trained. I think that is one of the best lab. And let me ask you a question, GV. Because you told that you have invited people to get training for this one. For flexible endoscopy surgery, whom should you think are the right candidates to do the procedure?
Now,
Surgeon, physician, or an entirely different community of doctors, a specialist that is endoscopic surgery. What I believe in gastroenterology is that we have gastroenterology, GI surgery, and in gastroenterology we have got luminal gastroenterology, we have got endoscopy and hepatology. And in endoscopy, it will become another specialty soon, whether surgeons and physicians who are interested in endoscopy can join. Endoscopy will again get divided just like cardiology, invasive cardiology, non-invasive cardiology. Endoscopy will become a diagnostic endoscopist as well as our advanced therapeutic endoscopy or endoscopy people with flexible endoscopy surgery interest, like surgeons or physicians or endoscopists.
See, basically, my idea is actually anybody who has got a good hand-eye coordination is the person who can do minimally invasive surgery. This is point number one. Actually, not all surgeons are trained to do laparoscopy again. Now, first and foremost is anybody who's got good hand-eye coordination can do both endoscopy and laparoscopy procedures. It is applicable to both endoscopy side and the laparoscopy side. Now, people who are interested to do this, actually, it is not that you can practice because it's becoming a separate specialty now. The endoscopists, the interventional endoscopists and the laparoscopists or interventional surgeon, they're getting integrated. I think very soon we'll have a separate specialty, a separate endoscopic surgeon they will be called as, who will be trained to do these procedures. Obviously, not everybody will be doing these procedures. Actually, it will be restricted to some people who have got good expertise both in endoscopy and laparoscopy. So it will be a separate breed of surgeons. Actually, I'm not. On that ground, I personally feel actually because surgeons should be slightly have an edge because they've already trained on the surgical side. They may have an edge to get into this specialty as compared to endoscopists. But I think the endoscopists are not far behind. They're getting very aggressive. They're understanding the entire process. And then now, I think it's a matter of time. It all depends on who becomes aggressive, who understands the thing, and who wants to learn this and then become this new technology savvy surgeons.
Yeah, as you rightly said, actually, this surgeons should be having an edge over the endoscopist, but
Maybe,
still,
yeah, right.
Probably because he knows the three-dimensional anatomy well. But
maybe we'll have the gastroenterologist now. I think maybe they'll start posting this interventional gastroenterologist for a surgical posting. We don't know. See the new programs that are coming up. Maybe with anything can happen. Actually,
I do agree with that. I think surgeons will be very more confident in handling this type of dissections and also. I think surgical specialty, it will become a surgical specialty. So endoscopy surgery, I think that, or I foresee that this will become an entirely different specialty of gastroenterology. That is what I think. And surgeons will definitely have an upper end, but definitely there are GI gastroenterologists who are really interested in this type of procedure they can do. I don't know whether GV rumors that Sidney Chung actually,
yes,
he is actually a surgeon and an endoscopy. He had got FRCS as well as MRCP. He has got both.
Actually,
so there are
Sydney, Sydney incidentally is my mentor. Actually, I learned my laparoscopy with Sydney actually. So basically,
I too went there. I was also there.
Right.
Yeah, actually, the surgeon and the endoscopy has to sit together and
yes, absolutely.
Further development of the procedures. Dr. Rudra Acharya is there. He is asking some questions about pancreatic pseudocystogastrostomy. Dr. Rudra, can you please unmute your mic and ask the question directly?
Yeah, Dr. G V Rao, nice talk. Actually, one of the most advanced talk and very futuristic with the combination of laparoscopy and endoscopy. But do now artificial intelligence has come up to say that you do scopies and you don't yourself see the vision, and let us say from past 1 lakh cases there is a standardized reporting, and you can get away with a fresh reporting without having a direct access or doing a direct reporting. That is number one. Number two is how the like in robotic they are now doing imaging integration. So if there is a tumor, is there any imaging integration coming up in the advanced technology in endoscopy, upper GI endoscopy?
Yeah, very right. See, artificial intelligence cannot replace natural intelligence. That is one thing actually. But why it is becoming popular is actually, Mathew will agree with me that, see, especially when doing colonoscopies, there is a data to show that some colonic polyps are being missed. Now, this incorporation of artificial intelligence, it makes sure that you're not missing anything. Second thing is actually what happens is whenever you're taking, suppose if you have an ulcerative colitis patient and then you have some lesion which we want to biopsy, it is likely that we take so many samples which may not be the actual pathological thing that we're looking at. So this identifies, it helps you to target the biopsies as in today. It is not replacing. It is not that I'm going to say that I'm truly basing my entire report on artificial intelligence. No, as in today, artificial intelligence is guiding us to do the procedure, but future, we don't know what is going to happen actually. So with more and more incorporation of artificial intelligence, actually sky is the limit and we just wait for the technology to come in and see what happens.
Thank you very much.
I just want to add something on that. See, the AI, artificial intelligence only will aid or it will add to the knowledge of the physicians. It actually cannot replace everything. But regarding your question that by the pictures, integration of pictures, whether it can be sometimes later, what is happening in the future, I can predict that probably in the future, diagnostic endoscopy will go away because it may be available in the market that capsule endoscopy. For suppose you have got GRD or you have got a GI disease, and you can actually use capsules and it will give you a printed report in the future or something like that, So it is probably that, in the future, diagnostic endoscopy may change and it is actually on demand by the patients can see. Doctors may not have to do anything. It is actually all artificial intelligence can do everything on diagnostic endoscopy. But for therapeutic endoscopy, it cannot. Actually, you need a doctor to do it, but AI can actually enhance the techniques by detecting more lesions or something like that. Thank you.
Yeah, there is one question from Pankaj Bharambe. How surgeons can learn advanced endoscopy and practice legally? Any membership or affiliation is required essentially for the practice of endoscopy by surgeons?
See, actually, I'll take the thing actually. See, now we have the new curriculums that are being laid down. All curriculums of surgical gastroenterology and even general surgery curriculums mandate that they have to learn some endoscopic skills, surgeons especially. So it is put up to the government. Actually, even all the curriculums across the globe have this practice of surgeons to know some amount of endoscopy. So it is not, see, let us be very clear. We are not competing with gastroenterology. What most of the surgeons at the periphery want to do is some upper GI endoscopy. They're not even bothered about colonoscopy. So even this is the practice across the globe. Actually, now, if you see the SAGES, officially the American Society, now, because of the screening colonoscopy, limitation of the number of endoscopies available to do the procedure, they're looking for surgeons to train. So now we have an official SAGES fellowship to train surgeons. We have now already trained 2 people actually who come to us. So SAGES officially sending people to train people. Now it is all in the interest of the patient. It is not of any gastroenterologist or a surgeon doing the procedure. we have a periphery, a patient who requires an endoscopy procedure, a gastroenterologist are not available. What do we do? So basically, it is not that the surgeons are trying to learn all the endoscopy procedures. It is basic endoscopy, coloscopy, and people who can do ERCP, who want to do ERCPs or advanced thing are a separate set of people. They're not practicing conventional this thing. Let us be very clear. So this set of people who are trying to learn endoscopy and want to learn only some basic things to make procedures safe and the interest of the patient. And I don't think this is competing with anybody else. So actually, even the surgical gastroenterology curriculum that we put forward to the National Medical Council recently, actually Avinash has put up the thing just actually 3 days back. It incorporates endoscopic training for people who are undergoing surgical gastroenterology training.
I think, most of the centers where GI surgery is being PG course are there. There is a posting for endoscopy.
Posting for that, yes, absolutely.
And I also think that, the surgeons who are interested in endoscopy, they are a different set of people. It's not that they should have a basic knowledge in endoscopy, definitely is that only they can get initiated on endoscopy. But the people who are doing interested in certain things, hepatobiliary or pancreatic surgeons, they may not be doing endoscopy practice at all. But there are people who are interested in flexible endoscopy surgery. They are actually concentrating more on that. So people are interested in minimally invasive surgery. They are actually considering that. So similarly, in endoscopy or in GI gastroenterology also, people are actually subdividing into them. Even in endoscopy practice, there are people who are interested in ERCP, as you told. They are interested in cholangioscopy and all those things. There are people colorectal practice. There are people who are interested in flexible surgery. So I think this is set what you want, you choose, and then you excel on that.
See, if you have the thing, actually, see, it all depends. See, in my center, actually, it all depends on how much time you can spend and what you're interested in. See, in my practice, almost 30% of the time I use endoscopy in operation theater for various things, for anastomosis, everything. Actually, you understand where if you have the endoscope, actually, it's very, very useful, actually, handy thing. It all depends on how much of interest that you have. And suppose if in my theater, suppose if I ask the endoscopist to come in whenever I want them to come in, it's not possible. So we have to learn some basic. We're not doing any advanced endoscopy there. We're just doing some basic endoscopy, colonoscopy. I think that can be learned. See, now we have learned choledocoscopy, we know. We have to do intraoperative pancreaticoscopy. See, all these things are band-aids that the surgeons know have some endoscopic skills and just to maneuver how to know. We all manipulate choledocoscope. So I don't think it's not a competing specialty at all, please. Actually, I strongly deny this competition between endoscopists and laparoscopy.
There should not be.
Yeah.
There should not be any, and actually there is
absolutely.
not. If you work in a good center, there is no competition.
Absolutely.
Actually, it all depends upon when you practice alone, and I think there is nothing.
That is not the reality in the periphery. In the periphery, actually, they usually fight each other.
No, that happens, Baiju. If what happens is, actually, see, we have to understand the thing also, actually. Suppose people want to practice both endoscopy and surgery together, that becomes a difficult thing, actually, especially in a peripheral place, actually. So, but especially in tertiary, but it could be, actually, I know some people, actually, there's some surgical gastroenterologists who are totally into endoscopic practice.
In India also, there are actually examples. No?
Yeah, there's a lot of people, actually.
Surgeons
but again, there are some surgeons who are totally into endoscopic practice now. So it's a variable thing, actually.
Many people are there as endoscopy.
Yeah.
Dr. Lashmikant is asking about a poem. Dr. Lashmi, can you please unmute and ask the question directly?
So, good evening, G V Rao. Excellent talk, sir. I think you are the team man, and the success of your team is because of your teamwork. So we are very happy. Wherever we go abroad, first thing is they ask notes, Hyderabad, this center, are you related to that? So that's the great team and the poem what you have spoken. Sir, as a surgeon, one question, because you do a lot of good laparoscopy, and regarding the poem, do you think a poem is little exaggeration, or is it showing any long-term complications, or is it in a way close to the conventional hairless cardiomyopathy which you are seeing?
Now, Lakshmikant, this actually, people who have seen this myotomy being done, there is no question that the myotomy can be done superbly from the endoscopy side. There is absolutely no question on that. Now, the question that happens is actually, and obviously like any other procedure, if you're not trained properly, please, if you're not trained properly, obviously you will have some complications. You will have some complications. Even during procedure or maybe post-operatively. I mean, there's no procedure which can be done without any complications, obviously. So let us be very clear on that. So it's a surgical procedure, obviously some complications could be there. But the biggest thing that we discuss about is the post-poem reflex. That is what, see, nobody discusses, I mean, so many meetings I've attended, nobody discusses about the intraoperative complications or the post-operative complications. It's all, everybody is bothered about the late post-operative complications and the reflex. Now, this reflex, yes, actually, I don't know whether it is exaggerated. I mean, I really can't say, but we've been on the laparoscopic side, we have been doing this fundoplication, so we're quite happy with it. But the data shows that not all patients have this reflex symptoms. Now, it's a way to debate actually what is reflex, whether it is clinical evidence of or endoscopic evidence of reflex, or you have 24-hour pH-metry. So you can debate on this, but ultimately it depends on whether the patient is having any symptoms of reflex or not. These are the patients obviously will require some sort of a fundoplication. So patients who are followed up, so there is a debate thinking that not all patients of LS myotomy will require a fundoplication. You understand? Because there is endoscopic data to show that almost 70% of the patients do not require any PPRs, anything of that sort. So that is a debatable thing. So as of today, actually, I'm convinced about the endoscopic dissection. I'm completely convinced. But patients who have this reflex after this, I'm totally convinced that they should require a fundoplication. As of today, an endoscopic fundoplication is just experimental, and we still have to have more data to show that it can be done through endoscopy.
Yes, sir. Thank you.
GV, Baiju, can I add something on that?
Please,
See,
please.
you know that poem, there is no doubt, it is shown that it is at least as good as lap LS. But the problem comes is regarding the GERD. And truly speaking, the symptomatic GERD reflex symptoms are not that common. But if you do a manometry or if you do a 24-hour pH, which is quite common that you see nearly 50% of people after poem surgery, they can have it. Why? Because actually we are doing a cutting of LES muscle. If you do it rightly, probably this may come down. But I'm telling you, symptomatic GERD is not that common. If somebody has got a symptomatic GERD, please go for lap surgery. And regarding the type of achalasia which should benefit type 1 and type 2, either a poem or lap LS is fine. But in those patients with achalasia cardia and a hiatus hernia, I would say that this patient should go for surgery because he definitely requires a fundoplication. It is not a candidate for poem surgery. But in type 3 achalasia, I don't know whether GV will disagree with me. Type 3 achalasia, suppose you want to have a dissection much higher up, probably poem is better than doing a lap.
Yeah, we have some definite indications, like a jackhammer esophagus actually. So you can do a full thickness myotomy. Actually, the endoscopy is a good thing actually. As rightly said, actually, there are some limitations. It is not like a barber-shaped phenomenon wherein it comes to the endoscopist and do a poem for every procedure. We have to categorize. Now, actually, we are practicing evidence-based medicine. I think we have to categorize which patient has to go for surgery, which patient would benefit from endoscopy. I think now with data coming in, I think there is some amount of discrimination now. So like any procedure, like actually, I mean, when you're practicing evidence and you have a team working in it, actually, then that makes a difference. Actually, then you can categorize which patient. Otherwise, I'm sitting at AIG, I'll not be doing any procedure actually. I'll close down my surgical department and go.
Your friend Dr. Subramanian Rao is there. Can you please unmute?
GB, it's always nice to see you. And then listening to you is always fascinating because being a Hyderabadi, I think I'm proud to be Hyderabadi because GB himself is an Hyderabadi. And each time you keep adding things that really fascinate. You are such an innovator and so much into basic research now that makes us feel very proud. And we keep on waiting year after year for you to really come out with new things. so much of research is happening in our own place. That is something that is really wonderful. I'm not an expert both in endoscopy or endo-laparoscopy, so I would not be able to add much. But the fact that, see, I would only say that artificial intelligence is something that would flatten the learning curve more than anything else. For an expert like you or Dr. Nageshwar Reddy, it may not truly help you to that degree. It does help you. Anybody who has time and expertise, both, I think artificial intelligence does not truly help. But for the learner, I think it really flattens the learning curve, and your students would not take the time that you have taken to reach here. So that is the best part of artificial intelligence. It really adds to your lack of that intelligence at this point in time and make you much more intelligent.
Thank you, Giri. What you said is absolutely right. This artificial intelligence, actually, we just have to wait and see what gets into clinical practice, what not gets into clinical practice. Suppose we are doing that ICG on the laparoscopic side right now. Now we have a slightly more objective. Now we're getting artificial intelligence incorporated into ICG to see what is the objective evidence to show and what is the absolute objective vascularity of the at the anastomotic site and all. So artificial intelligence is coming in various stages, and it all depends on what we accept, what we don't accept actually. But everybody will have their own things to get into artificial intelligence. Big thing right now, heart specialty. So we just have to wait and see and take what is best for the patient.
GV, I think what Subramania has told is partly true, because for the youngsters or the newcomers, AI will help a lot. Yes. Because, by looking at the pictures, because it has seen lakhs or 100,000 pictures and made a summary on artificial intelligence. Similarly, what you have seen for last 30 years, and that is actually probably true that artificial intelligence can help a newcomer and rapid diagnostic. And also the errors can be reduced by using artificial intelligence. So it can pick up and say there's probably something is there. So you spend a little more time in that area. So that is true. Otherwise, it may not. But I'm sure in the future, AI is going to take over.
Actually, it all depends on what we have practiced. Actually, Subramanyeshwar will agree with me that actually when we started practice, we did not, some of the centers did not even have the energy source actually. So they used to ligate each and everything with the catgut actually. You understand actually? So if the current day generation surgeon, if you talk about that, actually nobody will accept that actually. You understand? So it all depends on at what stage you are getting into clinical practice. So tomorrow, a decade from now, people are totally into an era of artificial intelligence. They're no more bothered about the white light endoscopy or white light laparoscopy. We don't know. They're into totally different era. They're entering into an era, totally different era, and their exposure starts from that time. So they'll have to take it to the next level.
I think that's true, and moreover, it all depends upon the entry point into your practice.
Yeah, entry point into clinical practice. At what point you're entering into clinical practice?
I have been visiting your department since Medina times. See what happens in the development vacancy. And another thing which you made a comment on, that the anatomy needs to be rewritten. I think that is true. For a person to start learning endoscopy through endoscope, for him the anatomy is different, and it's actually what you learn from first. I really, and GV, it was a wonderful talk, and I thank you. I had to leave early to go somewhere. Thank you so much, and Baiju, thank you so much.
Thank you for joining, and we'll continue for one or two questions. Thank you, Dr. Mathew Philip. Ananda Narayan sir is one of the senior-most gastroenterologists in Amrita Hospital. Sir, can you please unmute and say your comments?
So, if I have to do a surgery on myself, I will leave it to my surgeon. Full faith on them. And in Amrita, they have a very good team of endoscopists. Rama P. Venu, a world-renowned endoscopist, and his team are available. But I'll leave it to my surgeon what he wants and how he wants to do. So let him be the final authority on how he wants to do the surgery on me.
Dr. G V Rao, do you have any comments on that?
So actually, yeah, very absolutely. I take your thing very positively, sir. Yes, actually, again, as I said, actually, it is all what we are used to, comfort level, what we are used to, and the level of thing that we are exposed to in clinical practice that happens to us to show what is right and what is wrong. If my teacher comes to me, he doesn't believe in endoscopy at all because he has never seen. Because I recently actually I met my professor of surgery actually who met me actually who is not exposed to endoscopy at all. Because and he feels that everything has to be surgical because he had a CBD stone recently actually, so which could easily be removed endoscopically. But because he was never exposed to endoscopy, he feels that only surgical removal is mandatory. So, but basically it all depends on, I mean, I'm not denying it actually. It all depends on surgeon. Surgeon is the best person to decide. But at the same time, I fully agree with the gastroenterologists also seem to understand the entire the physiology very well. I think it's a combined effort of both the people to see what is best for the patient.
Yeah, Dr. Ashok Puranik has raised his hand. Can you please unmute and ask the question?
Oh, yeah. Can you hear me, sir?
Yes, sir.
Okay. I'm Professor Puranik from AIMS Jodhpur. And I really enjoyed your talk, Dr. G V Rao. And I can say you are the innovator and would be a great torch bearer for laparoendoscopic surgery. And I see a great future wherever we are using scopes to see intraluminally and wherever you are using laparoscope to see extraluminally to operate. And this combination can happen everywhere, whether you are operating in chest or upper abdomen or lower abdomen. So I see a really great scope for all this thing. At the same time, right from the lab, your experience will be brought down to your experienced people in the bigger hospitals, later on imparted to the all medical colleges. And for that, I think we really need to make train our postgraduates and the younger doctors in the present. They should be exposed to all the modern gadgets, right from endoscopic ultrasound to laparoscopic ultrasound, all kind of endoscopes, all kind of bronchoscope, laparoscope, colonoscopes, everything. And this combination can really work deadly along with artificial intelligence. Artificial intelligence, certainly it has got a lot of use in robotics and wherever there is an image-guided surgery is being done, because with this virtual reality, one can really utilize it in safety purposes especially, and we can really reduce the complication. Having said that, I think I would suggest you that if you are using a lot of endoscopes during your laparoscopic surgery, it will be worthwhile doing a kind of publishing a paper on some randomized control or your observational study, whether this is really going to make a lot of difference in the safety, lessening the time, approaching the difficult cases, avoiding complications, reducing the complications. There are so many things which can really be imparted, and this lesson can go to the wider audience. This is just comment from my side.
Thank you so much, Ashok. Actually, I know the amount of work that is being done at the institute. Actually, have kudos to the work that is being done. Thank you so much for those comments. Thank you so much.
Dr. Thomas Varghese, oncosurgeon from Cochin, is there. He was at Tambubo. He has some comments.
Hi, Dr. GV.
I thought, hi, good evening.
Though personally we haven't, I don't think we have ever met, but I'm watching you through Baiju's big platform most of the time, and giving your expert ideas. Anyway, this presentation, what you did is like a Hollywood movie, and for the futuristic outlooks, excellent. I would say this is one of the best presentations where people can generate interest, and that interest in the youngsters will create more and more opportunities for more and more modern technological advances. All said and done, everything in cancer remains on tumor biology. That is the foundation. Whatever technology you do, whatever method you do, whatever methods by which you operate, ultimately the patient's life depends upon the tumor biology.
Absolutely.
that is never transformed or translated or interfered by the technology by which we are using for a procedure. Having said that much, I understand that even in Japan, where I got trained for my upper GI work as a surgical oncologist, that endoscopic mucosal resection came in a big way, and it remains for the early lesions. But these early lesions, when you look at it, these lesions could be of different biology.
Yeah,
this could be clear cell, it may be a different undifferentiated tumor, maybe a differentiated tumor. I'm talking about the stomach or esophagus.
Absolutely.
Now, we do an endoscopic mucosal resection or a combined endoscopy with laparoscopy and all. And those patients who are done this minimally invasive endoscopic procedures, how do you follow up them? Because when you find tumors in the mucosal aspect, that is only the tip of the iceberg. Reason being, if endoscopists say the tumor is confined to the mucosa, and even your CT or whatever tool you adopt, they say the lesion is there, but finally the pathologist will say in a open surgery or whatever surgical specimen that there is submucosal extension that diffuses or spoils the whole show, because at a distance from the primary site of resection, tumor can recur.
Absolutely.
So my question is, when you do as an oncology surgeon, surgical oncologist, when you do a procedure like endoscopic or minimally invasive through the new whatever the interface between endoscopy and laparoscopy, how do you follow up these patients based on the histology? What advice will you give? Because people will enter into the field without understanding what is oncology. They will start resecting. Because you have said the technology is very good, handy. I even wonder that maybe 5 years down the line, your robo, along with your artificial intelligence, you may sit just not in the console. You may sit in the coffee room and tell the robo, please do this procedure. This is acceptable. How do we know that may not come up? But when you say about the tumor biology, based upon each type of tumor, how do you follow up them? And if you find a recurrence, or if you find a nodal disease in the lesser curvature areas in the follow-up period, how will you tackle them?
This is a very good question that you asked, sir. Actually, now this has been often debated actually across the globe. Now the Japanese, both the endoscopists have pushed this endoscopic dissection to a next level, basically because they started picking up lesions very early. Now, very early, what I mean actually, you must have also seen actually the basic timing of endoscopy that is required to do a conventional upper GI endoscopy in a Japanese center is about 40 to 45 minutes. Whereas we do it in our country, maybe it takes about 2 minutes to do an upper GI endoscopy. So the standard time that is given in Japan to do an upper GI endoscopy is about 45 minutes to pick up each and every, and then take pictures of every possible thing under magnification endoscopy
and under fluoroscope and under different technology.
Different technologies.
Yeah, so to pick up the lesions which are lesions.
Yeah, absolutely. So these Japanese are able to pick up such early lesions, and they have shown, because there is hardly any metastasis, lymph nodal metastasis in this, they started practicing this procedures. So obviously, actually, we have a lot of senior Japanese surgeons who started presenting this data, who started showing that over the period of time, because of the advances in imaging and early pickup of gastric lesions, the number of surgeries being done for advanced surgical procedures is getting lessened and lessened, and the endoscopic mucosal resections or ESDs are becoming popular because the rate of pickup. And they have shown that these patients are being followed up extensively. And I mean, I don't think any other data coming from any other centers that can be taken with pinch of salt, but the Japanese registries are absolutely stringent, and they followed up and they show that lesions, especially early lesions, mucosal lesions, are doing extremely well with on follow-up. But as you rightly said, these patients need to be closely followed. We cannot, I mean, like we have a regular follow-up following colorectal surgery or a gastric surgery, these patients have to be followed up and they have to be put on continuous surveillance. It is not that we can just say that they're treated and then we just
for a new surgeon entering into the field or an endoscopic entering the field, how does your follow-up advises based upon the histopathology? That's my point. Because
Yeah.
a clear cell cancer will not be the same way like.
Absolutely.
So how do you tell them?
So based
or you
on the
advise
biopsy, I think based on the biopsy, as you rightly said, based on the biopsy, I think suppose if it's an unfavorable thing, I think these patients have to be subjected to conventional surgical procedure. I strongly believe that. If you have anything that is unfavorable, I think they have to go for conventional surgery.
Because if you do a PET scan also, clear cell cancer doesn't show the same way like
absolutely. Absolutely.
So these patients will be at risk. We have done a good job. We have not done a scarless job. We have done
Yes.
everything beautiful. But
Yes,
should it necessarily translate into survival?
Yes,
That
they
was
have to be. These patients obviously have to be told that they require conventional surgical procedures. Absolutely. There's a lot of gray areas which we have to know. And if it is not that we can just say that do the procedure and leave the patient. Obviously, these patients require close follow-up like what we've been doing actually. And now obviously we have on endoscopic surveillance, basically now with good imaging modalities they have on the endoscopic side. And especially, see, this has to be dedicated center. Please, actually, I often say that suppose if you have done an endoscopic submucosal resection, you have to follow up this thing and then do good imaging, endoscopic imaging or enhancement imaging to make sure that these patients do not have any recurrence on the luminal side.
See, my another area of interest is thoracic oncology.
Yeah.
Now you are telling that we can go do a mediastinal endoscopy to the esophagus. Now all said and done. And the third space we are discussing. Now, in your clinical real practice, are you doing it now or it is
No, mediastinoscopy. See, what happened was as the third space endoscopy is becoming popular, now what is happening is inadvertently, sometime when we are doing the third space endoscopy, people are entering into the mediastinum. And there are some areas now that they've got a lot of confidence saying that, okay, they've entered the mediastinum and the amount of surgical emphysema or the post-procedure has some complication, but they can be managed. They're saying, is it possible? It is just experimental work. It is not being done to see whether we can maneuver the scope in the mediastinum. You understand? I'm not saying it is being done. It is an animal experimental work which is done to show both under fluoroscopy and under this thing to see whether we can maneuver in the mediastinum in restricted areas. It is not that we can just go into the mediastinum left and right by making one single incision. No.
Yeah, the point which you raised was very interesting and important, that to learn, unlearn and relearn the anatomy from within outside. The mediastinum will be one of the most dangerous area
thing to get in, yes.
Because I do esophageal surgery regularly. I know even a small chyle leak and what misery it can create, and a small leak into the mediastinum can cause what damage to the patient.
What damage it can cause. Absolutely, I agree.
Peripheral laryngeal nerve injury and even a small blood supply to the bronchus, coming along with the azygos vein. If you damage it, how much of the trauma is happening to the. So when we enter with a scope, with the anatomy what you have to learn, relearn.
Yes,
will
absolutely.
Be totally different from the anatomy what people have learned. And the last question to you. Very fascinated to read and learn from the big man like G V Rao doing through the vagina. You are going and operating on the colon. I think men don't have a vagina, so they are unfortunate that they have to still go to laparoscopy for the job. All said and done. How, if a vault recurrence happens, how do you know? How do I did not complete.
Yeah.
This is a hypothetical question. I know you are an expert, Dada, in this, but people who are. My question is: if a vault recurrence come in the procedure, how do you know the person, the gynecologist who is going to see the patient for a regular checkup, will say that this is a cancer which is from de novo from the cervix, because adenocarcinoma is very common, unlike in other areas. I'm an oncologist, surgical oncologist, so I had to treat almost all the cancers. The adenocarcinoma, not unlike squamous carcinoma, is coming as a common feature in the cervix, because the endocervical epithelium can cause adenocarcinomas. And your pathology report, if suppose a recurrence comes in your hands, it may not be there. But I'm putting a hypothetical situation. How do you know whether it's a cervix cancer, adeno, or the colon cancer, which you have gone through, make your beautiful, is the punch? How do you, gynecologists will differentiate? They may go to a gynecologist only when a bleeding comes.
It's a very good question. I think it's a very difficult question to answer also. But whenever you're using this natural audipus for extraction of specimens, actually, which is one of the routes that is accepted, especially in minimally invasive laparoscopic surgery. So we use the standard extraction ports to make sure that you're not contaminating the port, the vaginal port during the extraction. We take all those precautions. Actually, it is not that it's extracted for just the incision. But your question, the question raised is absolutely mandatory. Actually, if you're not having any of this thing, it is likely that actually, suppose if you're not taking all the precautions and if you have a recurrence, yes, there'll be a confusion as to where the primary has started from, whether it started from the cervix or in the vaginal wall.
Oh, I did not mean that you are not extracting with all precautions. No, no, no. Please don't take me that way. When we manipulate a colonic lesion,
yes.
Please let us. This is not an oncology discussion, so I don't want to go to that areas. Early lesions are the only lesions which should be operated through any of this method. When the lesions are more advanced, they have to receive neoadjuvant treatment. That is the world standard today. After learning and understanding about more and more of IHC and the patient biological behavior, KRAS, NRAS mutations, BRAF mutations, and all, we should not be operating on lesions which are locally advanced, being done today. So that is, suppose somebody is entering into the field and going to do a locally advanced lesion through this technology, he is manipulating and bending, and so many tumor cells will be deposited. They go to pouch of Douglas, and no doubt.
Yeah, that is criminal to do the thing. That I don't think I should. Locally advanced tumors, one thing I think we should not practice doing this procedure.
Yeah,
very clear actually. Actually, that's what I said. Seeing one procedure is not that you can translate into clinical practice. We have to understand which cases you have to take for these sort of interventions. Actually, we have to be very clear.
With due respect to you, last one more question, please don't bear with me. Now, this topic was more in favor of endoscopist versus laparoscopic surgeon. I wish there was an interface between a surgical gastroenterologist and surgical oncology and oncology interface, so that we should have went to do oncologically based laparoscopic procedures. It would have been nice.
Yeah, definitely we'll be having a session on that also.
Thank you. Thank you very much.
Thank you, Thomas Varghese sir, for the inputs. Your viewpoint and the onco point of view. Now, actually, if anybody wanted to have a question, please raise your hand, or we will close this section. Yeah, actually, there is no question from the floor. I take this opportunity to thank Dr. G V Rao and Dr. Mathew Philip for the wonderful session and for the inputs. And there were a lot of interesting discussion from the floor. Actually, the YouTube link is put in the chat box itself. You can copy that link from the chat box and view it later. Thank you, sir, for your final.
Thank you so much, Baiju. Actually, at the same finally, sincere thanks for the incredible work that is being done under SENADHIPAN Education Foundation. I just hope that you keep doing this great work, which I hope the entire idea is to share with you the new concepts that are emerging from across the globe, and people who are getting into clinical practice, both endoscopy and laparoscopy, they should be aware of the thing. And like when we started practice, we chose one particular area to pursue our career into one particular direction. So the opportunities in current day are so vast, and suppose people are exposed to these things, I think people would take interest to make sure that they specialize, subspecialize in areas of interest. Obviously, even in oncology right now, people know that people are subspecializing into one particular area. They're not doing general surgical oncology. So this is more this thing to showcase what is happening in select patients, what is happening across the globe, to see how people can cooperate to do some of these procedures, to do some organ-preserving surgical procedures. That's the concept of this entire thing. And it is likely that a set of people would be interested in pursuing this career. I hope this would initiate some interest for people to learn some endoscopy skills, to make sure that they are not out of the race tomorrow. See, we don't know what is going to happen tomorrow. Tomorrow, the surgical practice could be totally different. If we don't have some basic endoscopy skills, we may not be able to do some procedure. So this entire concept is to make sure that surgeons should have some endoscopy skills. They should learn to make sure that. Thank you once again for the excellent, and thank you for, and I deem it an honor to be on your foundation lectures. Thank you so much, and I hope I can come back and talk to you in some other session some other time. Thank you so much, Raju.
We are really honored to have you in this platform. We expect you in the future, our endeavors also. Thank you for your participation.
Thank you so much.
We close the meeting. Thank you all.
Thank you. Thank you.